Hello, everyone. My name is Dr. Maurice Scholes. I am a peds rehab doctor from the proud city of New Orleans, Louisiana, board member of the National Medical Association. I'm here to welcome you all to NMA Talks. Tonight, we have a distinguished panel of experts from every perspective to talk about autism in the African American community. And with that, I want to welcome my fellow guests and panelists, and I'd like to introduce them and have them introduce themselves. First, I'd like to start with Dr. Jennifer Walton. She's the chair of the National Medical Association Pediatric Section and the Associate Division Chief of Developmental and Behavioral Pediatrics at Nationwide Children's Hospital, where Dr. Walton sees patients with a variety of developmental and behavioral disorders, including autism spectrum disorders. And she believes and advocates for equity, diversity, and inclusion of all individuals with intellectual and developmental disabilities. Dr. Walton, please welcome to the program and tell us a little about yourself.
Thank you. Thank you all. And hello, everybody. Hello, Facebook Live and where this is being broadcast. As Dr. Scholes says, I'm Dr. Walton. I am the Associate Division Chief at Nationwide Children's Hospital. I'm actually here in my office after seeing patients today. I also am affiliated with The Ohio State University, and I'm a Director of Clinical Services at the Nysanger Center, which is a University Center of Excellence in Developmental Disabilities. So we run a team, an interdisciplinary team, when it comes to the diagnosis and management of a variety of developmental and behavioral disorders, including autism spectrum disorder. And he is correct. And we will touch on today on the importance of equity, diversity, and inclusion, specifically when it relates to our African American community and our other underserved and other underrepresented minority communities. So I'll stop there. It's a pleasure to be here.
Fantastic. Thank you, Dr. Walton. My next guest is Ms. Pamela Collins. She is a Master's of Public Administration and MSA. That's a devoted mother of an autistic adult daughter and an advocate for people with autism. Professionally, she serves as the Deputy Chief of Asthma and Community Health Branch for the Center for Disease Control and Prevention. So in addition to being a health professional, Ms. Collins is a mother, and that gives her perspective a whole lot of weight and clout. Thank you for joining us, Ms. Collins, and please say hello to our audience.
Well, hello. Again, I'm glad to be here and honored that I was asked to speak, especially given the perspective, a parent's perspective of raising autistic child. And I've had my daughter, her name is Gabby. We call her Gabby. And she's been with me since she was 2 weeks old. So now she's 23. So I just want to be able to provide the viewers today an opportunity of looking at resources that could help. Sometimes, you can find things. Sometimes it takes a while, but not to give up. You still have to press on and continue to be strong and stern with these systems and agencies so that their child can get the best care and treatment that they need.
Excellent, excellent. In addition to me, Dr. Walton and Ms. Collins, we have Dr. William B. Lawson. He is a psychiatrist in Washington, D.C., and is affiliated with Howard University Hospital, where he received his medical degree from University of Chicago Pritzker School of Medicine. He's been in practice for more than 20 years. So in addition to a developmental pediatrician and a parent, I'm proud to welcome Dr. Lawson, a psychiatrist, to the panel. Please introduce yourself before we get into the conversation, Dr. Lawson.
Yeah, I'm very glad to be part of this panel. This is a very personal thing for me because I found out that I had a cousin that spent a lifetime in institutions. I'm from a rural community, and at that time, the idea of autism was just not considered. People were considered some sort of form of mental illness, which people would put away rather than trying to see what we can do to permit people to maximize their performances and to see who they really could be.
Excellent, excellent. Well, thank you all panelists for joining us. As a peds rehab doctor, I'm here to learn as well as to interact with all of you guys and hear your perspective. To get things started, I think it's really interesting to talk about people's journey to understanding that their child has autism and what they did. So the studies have really shown that more kids have been diagnosed by the age of 4 years old that were born in 2012 than were born in 2008. So we're doing a better job of actually diagnosing kids. And there's actually no difference in terms of prevalence between Black and white children. It looks like Hispanic children may have a slightly lower prevalence, but we don't know if that's sampling error or not. But what is notable is that Black children are usually diagnosed later. So even though this disease is the same amount of prevalence between Black children and white children, our children are diagnosed sometimes up to 3 years later. And I really want to start with Ms. Collins to talk about how her journey towards discovering her daughter had autism happened. And then I want to come to you, Dr. Walton and Lawson, to talk about the technical side from the treating provider side of that. Dr. Collins, tell us about your journey. You're muted there, Ms. Collins.
Okay, they unmuted me.
Mhm.
Okay, the journey was long, I would say. We found out that Gabby was diagnosed with autism around 3 years old. And as I said, I adopted her, and I had this wonderful social worker at the Department of Family and Children's Services that said, "Hey, why don't we go and have Gabby to have an assessment at the Marcus Institute, which is now known as the Autism Center." So we went there. She wasn't walking at that time, but she had some of the tendencies, as I guess you would say it, from the spectrum. They diagnosed her, and what I did is that after she was diagnosed, uh, 4 years old, we're going to start going to the school systems, and had an IEP, an individual education plan that we have for the kids who have special needs in school systems. And I had a meeting, and we were deciding what track Gabby was going to follow. Even though I had the diagnosis of autism from the pediatrician, the psychiatrist pediatrician, but I was getting pushback from the school system saying that they did not think that it was autism, because if she doesn't do this or she doesn't do that, like, she may not want to be touched. Autism kids are very much alone. She wasn't, um, and I had to really stand my ground, to let them know that we were going to follow the autism track, regardless of what his report stated. And got a little pushback, but again, like I said, I went through the system, and wrote letters and said, "This is what we're going to do." So, he still kept saying she didn't have autism, but nevertheless, she did.
I love that. I thank you for your persistence, Ms. Collins. And that brings up a great question for Dr. Walton. Tell us about, as a developmental pediatrician, how do you go about diagnosing a child with autism? What do you look for?
Excellent question. So it's important initially for all pediatricians, period, from the beginning, when you see any child, whether it's as a baby or at any well child visit, or when a parent has concerns about how the child is communicating socially, as well as overall, what are their language abilities, but how are they communicating and using the words or the ability for them that they should be able to communicate, but they're not. So we look specifically for their language abilities. We also look at nonverbal abilities. So how is their eye contact? As you
Mhm.
see, I'm using my hands in sort of a gesture format. Are they using any type of gestures? Can they wave, hi and bye? Are they shaking their head yes or no? And so, what can they understand someone else's social cues? So as a child gets older and they're probably talking to their peers, and that peer may have a look on their face like, can we change the subject? Is that child understanding that ability, that social cue? But then also, are there other behaviors or patterns of interest that people may call unusual? So, for example, the classic examples are, hand flapping or pacing or rocking, but then also just unusual types of just movements, period, with their hands. It may be very subtle. But then some children may not do that, I'll be honest. And so one child with an autism spectrum disorder is just it. One child with an autism spectrum disorder. It's a neurodevelopmental disorder, meaning you have to have a core impairment in social communication and social interaction, and then a core repetitive or restricted, I like the word restricted or rigid, pattern or behavior of interest. So they may not actually do hand flapping, but they may be fixated on a certain topic, whether it's trains or whether it's, vacuum cleaners or whatever that
Exactly.
topic is. So much
Exactly.
so that you try to change the subject and they will find a way to bring it back to that pattern or topic of interest they want to talk about. You have to have both of those before you go further in terms of that diagnosis. I'll also say this because I don't want to take a lot of time. The diagnosis of autism spectrum disorder should not be quick. Unfortunately, it's going to take time. There's not a blood test. There's not an image. It really involves a good interview from that parent, like Ms. Collins, or caregiver. It's also going to involve gathering information from that parent, from another environment where they're commonly located, like a school or a teacher, as well as hands-on, what do you see the child do? Have them actually do some tasks, and there are specific tasks they have to do in the moment. That's important too, to take all of that information and combine together before we make a diagnosis.
Excellent, excellent. That is very, very excellent information, Dr. Walton. So now that Dr. Walton has really laid out sort of what autism is and how she gets to the diagnosis, Dr. Lawson, I'd love for you to comment on what could this be confused with? In medicine, we say the differential diagnosis, or in lay terms speak, like what looks like autism but isn't autism, and what would confuse us and make people think it's something else. Dr. Lawson?
Yeah, I've been long interested in the whole problem of misdiagnosis of African Americans in terms of mental disorders. For a long time, we thought that we didn't get mental disorders, that our brains were such that we wouldn't be responsive to such things. Or if we misbehaved, it had to be some sort of pathology. So once, very recently, as a matter of fact, last year, I was asked to evaluate a young man who had thrown some water on someone in the metro. They called the police. They called everyone. They said this person must have schizophrenia, bipolar, or some other disorder. In fact, this is a young man who had autism, and who, in the very novel experience of riding on the metro for the first time, got very confused and responded by throwing water on someone. At other times, I unfortunately have been in long-term care facilities where I find someone who, if you develop ways of communicating, why is this person here? This person doesn't have any psychotic symptoms. This person doesn't have any kind of depression, but they're sitting here. Why is that? And often when people don't communicate readily, they jump in and say, well, they clearly has mental disorder, or they must be mentally retarded. And in fact, even though we know that spectrum disorder can run the gamut in terms of cognitive function, nevertheless, when people do not communicate in a way that they readily understand, or they're withdrawn or repressed, they assume that they have some sort of mental retardation, that they're incapable of cognitive functioning. They may do quite brilliant things like play the piano spontaneously or do mathematical problems. They said, no, they imitated from someone. They couldn't have done this themselves. They must have some other underlying condition. And also, it's very distressing when I see folks who become depressed because they recognize that no one can communicate with them, and the family members and everyone else many times will just say, what we say in the country, attached, which means that they're out of sorts. And then some folks even say that it's a sign of some sort of spiritual weakness, that they've been possessed. And many in our community still has said the idea that somehow they must have done some sort of sin or something that's caused them not to be able to communicate like everyone else does. So it runs the whole spectrum. Autism can be a very complicated disorder, can express in a lot of ways. But if you don't get a comprehensive picture and involve all the participants, you're going to be very difficult to find out the strengths that the individual has. It shows it's very important that a diagnosis or decision is not something made by one individual in one setting, in one set of circumstances. You must bring in the community, the family, and sometimes the community to clarify what's going on.
Excellent, excellent. You see why we have a developmental pediatrician, a psychiatrist, and a family member here talking about this, because everybody really needs to come together from different perspectives. This is fantastic information. And I really, really thank my panelists. I'm super excited just this far. We're barely 15 minutes in and I'm bursting with excitement. So one of the things that Healthy People 2020 put out there as a goal is to have the first developmental evaluation of somebody with autism happen by 36 months or 3 years old. Ms. Collins, you talked about your daughter was diagnosed by 3 years old. And as part of that process, we really haven't gotten there. And here in 2021, we're only about a quarter of the way there in terms of raw numbers of people meeting that criteria. Um, Dr. Watson, could you talk a little bit about the team of people that are involved in helping make that diagnosis, be it developmental pediatrician, psychologist, speech and language pathologist? Talk a little bit about that, Dr. Watson. Who are the team members?
You started naming them, which is great. And so no, like a developmental pediatrician, please note also, and though I'm biased, I'm a developmental behavioral pediatrician, a psychiatrist can also be part of the team. You definitely want a medical provider. So whether that's a developmental behavioral pediatrician, a psychiatrist, there are neurologists that are very active in this too. There are, and I don't want to forget our nurse practitioners that are also trained in this as well. That's really important. And then there are just some fabulous general pediatricians who've received extra training. So I want to be inclusive in this. You want a medical provider. You're absolutely right. You want a psychologist. You do want a speech language pathologist because they're great at evaluating not just receptive, what does the individual understand, expressive, what are they actually stating, and then also looking at pragmatic abilities, meaning with the language and vocabulary I have or don't have, how can I still communicate my wants and needs? That's really important too. So a speech language pathologist can look at all of that. Some teams also include an occupational therapist. So you wonder, why is that? Sometimes an occupational therapist can be very good at looking at different sensory concerns or texture concerns, which can come up a lot with our children with autism spectrum disorder, as well as fine motor abilities. We also have had physical therapists. We definitely have those individuals who, not to say they have a specific motor delay, but they can have difficulties with coordination and their balance. And so sometimes there are children with autism spectrum disorder that can have those difficulties, and it's good to point out and make sure to rule out that there's not another specific motor concern. So someone like Dr. Scholes, who's in pediatric physical medicine and rehabilitation, if I have to pull him in, I'll pull him in if needed. But you want all of those, and then most importantly, and maybe before you even get to the team, you want an audiologist. Sometimes it's very important when there is a child who has a concern for language concerns or social communication concerns, you want to make sure their hearing has been assessed. If there's a hearing concern, sometimes you can just stop right there and say, freeze. We need to make sure this child can be able to hear and understand. All of those elements are very important in part of a team eval, not just for the diagnosis of an autism spectrum disorder, but then with that, it's about the level of support. How can we better support this child or individual moving forward? So let's say I diagnose a child, and then Dr. Scholes, you got to stop me at certain points because I can go on. But in this case, I want to make sure people understand that when you diagnose a child, we look at levels of support. Meaning, I can have a child who has an autism spectrum disorder who may be at a level, who's going to require a certain level of support to help with social communication, or a substantial level of support to help with restricted and patterns of interest and behaviors. It's helpful to know that information, and that guides management in the next decisions. And then it's also important to know, where are they developmentally as a whole? Dr. Lawson brought up mental retardation, which from now on, I would like really for us to remove that term from our vocabulary and use intellectual disability. It is actually the more politically correct term. But then what are their levels of learning abilities, period? Because that plays a role too.
That's really excellent.
Know that as well. And so that we need to know all of that, because that's helpful to then guide a parent like Ms. Collins on next steps with the school, with the community, with next steps on management, what to do next. I'm going to stop there because I could go on, but I'll stop right there.
Thank you. That leads me to my next question from Ms. Collins. With there being a physician, a psychologist, a speech and language pathologist, an occupational therapist, and an audiologist on the team, when you were wading through all those different professionals, did they all talk to you with the same language? How did they connect with you, and which one really landed well?
Well, I believe that the Autism Center really gave me more information as to what the next steps were. Like, for instance, there are a lot of doctors, and you can imagine, just based on what we were talking about earlier, all that information for a parent to digest is hard. So that parent has to then make sure that if the audiologist or the physical therapist, occupational therapist are not in the same group, which we do have here, Children's Healthcare of Atlanta, so they were able to kind of look at the file to see how she was progressing working with that. So she did have all of those therapy. And the audiology thing is very interesting because Gabby was not diagnosed with hearing impaired until she was 4. There was something that was going on, and the therapist was saying, "No, she's not hearing impaired." And we're like, "Well, let's just go ahead and do one of those ABRs where they'll put them to sleep and look at the brain function of um, of her hearing." And she was then diagnosed with moderate to severe hearing loss. So again, I have another therapist that comes in, and if a parent feels that that therapist may not be giving them the correct information, find a second opinion because they may not know. And she was diagnosed with being hearing impaired.
I think
So,
that's an excellent, excellent story for people listening, is that you have to ask the questions, and when you get the answers, they have to make sense to you.
hmm
Yes, you're dealing with professionals, and yes, you're dealing with people that hopefully have not just the education, but the compassion to care for your
hmm
kids. But if the answers you're getting don't match what you're seeing, keep asking questions and keep pushing. And I think that if you don't take anything else from this talk, Ms. Collins, that is really, really hitting the nail on the head. Dr. Lawson, as we talk a little bit about misdiagnosis, differential diagnosis, different team members, talk a little bit about sort of how do you help families and individuals adjust to the shock of this information and sort of the psychological impact of knowing your child has something that's going to impair their ability to communicate and possibly show how much they love you?
Yeah, I think that's a very, very important point. And that is, some families go into just frank denial and just refuse to accept the idea that there's a problem that has to be solved. And so they then try to have super high expectations, do not recognize that additional services are needed, and essentially eliminate the person as functioning the person is in fact there. They act as if there's not a human being there. They treat him as if he's furniture. Or the other method is that they treat him as if he's a doll or he's an object, he's a robot, but not a human being. Forgetting that that individual has human feelings and can perceive, may not perceive it the same way, but perceive that there is some interaction with people around them. So a key point is to help them recognize this is a human being, may not communicate like you communicate, may not see things as you do, but they're there, and they still require your caring support and help and a helping hand. And the other is to help them recognize that the individual is capable of growth. That how the person is right now is if the person interacts with them and functions them as a human being, will grow in a way that will be better to work with them and to be able to relate to the rest of the family. And then the most important part is to recognize that these are the individuals or human beings as part of that can be part of a network. And many families struggle between one. This is not this is not from any side of my family. It must be from your side of the family, or this is not someone who is a result of something that I did. But work with them and recognize it's not your fault that this is what happened. That this is a genetical, biological factor. It's not from some sort of hoodoo curse. It's not from something that you did wrong in terms of childbirth. This is not something that is very helpful in terms of trying to determine whose blame it is. Let's look at where we are and let's build on where we are and be able to use all the resources to move forward to see what we can do to continue to have a functioning family.
Excellent. That is an excellent perspective. Again, for those just joining us, my name is Dr. Maurice Scholes. I'm a peds rehab doctor in New Orleans. I have panelists Pamela Collins, who's a mother in Atlanta, an autistic child, Dr. Jennifer Watson, a developmental pediatrician in Ohio, Columbus, and Dr. William Lawson, who is a psychiatrist based in Washington, D.C. So we have a very, very broad perspective of people from very broad different regions of the country. We've just spent the last portion of our discussion talking about diagnosis and identification and some epidemiology behind autism. Now let's move into the section talking about now that you have autism, so what's next? And this really speaks to me as a peds rehab doctor. You know, we're always talking about whatever the fancy thing they tell you have, you come to me to figure out what's next and what we're going to do about it. So Dr. Watson, talk about like now that you've had a child, you've had the team evaluations, you've come up with the diagnosis. Let's talk a little bit about interventions and what gives these kids the best chance to move forward and do well.
Okay, great. So that's such a loaded question, but I'm going to try. Okay, so here we go. I'm going to start with younger children first. So I know when Ms. Collins stated, you know, her child was diagnosed, I believe you said at age 3 or 4. The goal is, and I think the reason why we really wanted to talk on this topic today is to try to get children diagnosed as early as possible. Specifically, I would love before the age of 3, is because per federal law, all children between the ages of 0 and 3 years, if they are at risk of a developmental delay or have any type of developmental delay or diagnosis, including autism spectrum disorder, it's by law, those children qualify for early intervention services, which every state has to provide. And so it may be called something different in each state. And so, and I've been in 3 states and they call it all a different name, but the goal is they are qualified. They have to then have an evaluation by the state to see if they qualify for certain therapies and services. For example, speech therapy to help with their language abilities, or occupational therapy to help with their fine motor concerns, or how to handle different sensory disturbances or textures, and then physical therapy, or even some behavioral therapy or involvement with an early intervention type specialist. This is why we always try to push as early as possible. I know there are studies that have come out, and we can go back years back, and I know Dr. Lawson can speak on it better than me, that when a child is diagnosed with an autism spectrum disorder, you may have heard the term ABA, or applied behavioral analysis, which is a type of intensive behavior intervention that looks to the goal of how can we improve those social interactions and social communication and really rigid behaviors. And way back, they'll tell you, you know, you need 40 hours a week of this intensive behavior intervention. And then in reality, can we really do 40 hours a week? Is that really possible? And let's be real, it's not. And that's why, and even Dr. Scholes knows this, there have been studies that have just come out recently, like last year and this year, to show that, is that really the case? It may not be the case for every child, right? It totally may not be. And it may not really be the case for every adult who has to work, who has other needs and priorities to have met, and are trying to juggle so many things. So this is what I would do, or what we would recommend, and I think all of us on this call would recommend. When a diagnosis is made, and we make the diagnosis and we follow what Dr. Lawson said in terms of making sure you, that parent or that guardian, understands and really digests, okay, I know my child has this diagnosis. What's the next step? I usually then say, all right, let's focus on the next 3 steps of what you need to do. Really, that will involve who in your community can be of help and support, because you cannot do this alone. You cannot explore and search and find every therapy option alone and by yourself. It's just not possible. So then we look into the community. We'll look at what can your school system offer, specifically after a child turns the age of 3, because that's when the school will intervene, and it can involve preschool services. Or are we able to consider any additional private therapies to help with those social communication needs, speech, OT, whatever is needed? Or are there any other community agencies or organizations? Some states have specific boards of developmental disabilities or boards of other types of needs, including autism, that can provide a wealth of knowledge and support. And funding, seriously, funding, keyword, because this costs money. And sometimes insurance companies may not always pay for it. So we have to look and find extra levels of support. I'll end with this, and I'm not favoring an organization over another. There's what's called the Autism Speaks organization. It is a great organization. All of us on this call know this organization. It's a parent-run organization that has other advisories on that. And they have what's called a 100-day toolkit, meaning my child was diagnosed, my young adult was diagnosed. What do I need to do in the next 100 days? That can help guide you too in terms of this is what you should do for the first 100 days since the diagnosis. That way you're not as overwhelmed, and that way you can be able to say, all right, these are the next things I'll do. And then let's talk back in 2 weeks or a month later to figure out where you are. I called this person, hot mess, didn't work out. Let's figure out another option. Or I love this resource. This is what we're going to work with. Perfect. Let's keep moving.
That's an excellent point. And I also want to underscore something Dr. Walton said. Not every connection you guys make is going to be a love match. Sometimes you meet providers that just doesn't work out for whatever reason. That's okay. It's not an indictment of you as a parent. It's not an indictment of your child. It's not even an indictment of that provider. It just means y'all didn't necessarily jive in the way that a patient and a treating professional need to vibe. And that's okay. And you get to have the agency to move on. And a lot of people don't know they have that agency until a long way down into the process. Unlike how Ms. Collins was all over that and knew from the beginning where she wanted to make her stand and take up her space. I encourage people to take up space. Dr. Lawson, before we go back to Ms. Collins, I want to ask you, could you talk a little bit about the ABA approach to interventions versus the naturalistic developmental behavioral interventions, NDBIs? Because it gets to be an alphabet soup out there. And can you break it down for our listeners about what do these interventions actually do and what do they actually mean and stand for?
That's something I'm still learning a lot about because my residency training was in California. California was a big deal. The point we were told was that autistic people were like tabula rasas. And if you get basic kinds of behavioral techniques to have them to show appropriate behavior, this is how you speak, this is how you move, this is how you interact, and so forth. The folks that they may not have the kind of feelings that you have when you're seeing folks who are, quote, normal, but they're behaving in a way that they can work in society. And there's still a lot of people who adhere to that. But as noted, that is so difficult to do with resources. And one of the things I noted right away was that that's when I moved back to DC, found very few African Americans were exposed to that approach. There was much more focusing on getting people things like medications to keep them quiet, rather than trying to help folks to be able to function. I had the pleasure, to work with a person who was involved in terms of the Move Price program. This was in Philadelphia. Afrocentric group decided they were going to withdraw from all society and not have the folks exposed to the European stuff. And the kids that were involved in it, one of them had autism and got to his 20s, couldn't read, couldn't write, did not have very many social skills. But he got an individual who concentrated their effort in terms of developing his skills, working with him in terms of developing fairly innovative ways of changing behavior, showing them this is what it means when you see letters and books and so forth. And the individual now was able to finish college. This didn't take forever. In fact, it was about a 2-year program, but it showed to me, and I think to a lot of folks, that you don't have to have a structured behavioral program that's focused on each individual behavior, but that if you can have the flexibility to use what is there, that you can make tremendous strides in terms of being able to do what is needed to be done to have folks be able to function effectively.
Excellent. Thank you. I think we have a question from our audience. Chastity Nunez asked Dr. Nunez, why are girls diagnosed with autism less often? The socialization of girls, even early on, seems to make them better at masking the symptoms. So do they learn how to mimic normal social behavior better than boys? How do you explain that? Please, and I'll punish you, whoever wants to take it. Dr. Walton?
So I could try. I mean, it's an excellent question, and it's hard because if you look at the current stats, and ever since the beginning of when autism was diagnosed, boys are diagnosed more often than girls. for a variety of reasons, some of which are complex and unknown. It can be tough for whatever reason to be able to catch a girl to really demonstrate those core symptoms. It could be because they're already have been able to mimic or sort of hide in the crowd and not really become aware or make it as clear in terms of something's not right. I remember finding some girls and they're sitting there and you think like everything is great until you go deeper in conversation and really are they able to expound and understand certain emotions, and then verbalize it back to you. I always love asking older children sometimes the questions like, why do people get married? And it would be interested in some of their answers. And they're like, people just need to be together, or just like, do they really understand the relationship further? And for girls, it can be difficult. I mean, right now, the stat is 1 in 54 children are diagnosed, but it's 1 in 34 boys, 1 in 144 girls. And so it's really, since the beginning, more difficult to diagnose girls. But not to say there are girls that totally have it. There are some girls, just like there are boys, that classically we go through their criteria, we get them evaluated comprehensively, it is clear. And then there are other girls and other children, other boys, it is a downright puzzle. I've definitely had children where we have done evaluations, and I've even had to tell parents this is a puzzle, to the point where I might need to wait before I give the diagnosis. And I don't like doing that. But at the same time, I want to really be upfront and transparent and say, this is the reason why I have some concerns. That child demonstrates a lot of fabulous strengths, is able to still explain certain wants and needs wonderfully, but then not in other areas. But is it really clear? So I want to give it time. And so that's why, and I bet Dr. Lawson can speak to this, way back in the day, some children really weren't truly diagnosed until age 8 years. Usually that's because they've really been in school, elementary school, usually at age 8, that second or third grade academic demands are really at a level where it's going to show that there are definitely some difficulties and weaknesses, and we really see it. That's why for some children, though we like to diagnose before the age of 3, sometimes we're going to wait it out and say, you know what, you're demonstrating some fabulous strengths. We're still going to support you, but then let's see you back. So
That's
sometimes
excellent.
we like to take our time. And with some girls, you got to take the time.
Excellent, excellent. Ms. Collins, you had a girl that was diagnosed with autism. You told us your story. One of the things I'm interested in is which of these interventions did your daughter have? Did she have an ABA intervention? Did she have this naturalistic developmental behavior intervention? And the difference for our audiences is the ABA is sort of very prescribed textbook kind of interventions, whereas the naturalistic one is more focused on what the child will have to actually do in their regular, ordinary environment, as opposed to what the textbook says you should work on. So it's more applied, if you will. What did your daughter get in terms of interventions?
Well, the ABA came later. I would say probably around 7 or 8. The first thing that we did do is, of course, Babies Can't Wait, which is
Mhm.
another program that deals with children who are not thriving like they're supposed to.
That's the early intervention program in Georgia.
Yes, as
It's
early
called
that's
Help Me
babies.
Grow in other places, or Early
Yes,
Steps in other places, but it's called Babies
correct.
Can't Wait there in Georgia. Yes.
So then that program is from 3 to 4 or 5. I think 3 to 5.
Hmm.
Once that is, because at 5 or 4 to 5 rather, they're going into school. So then you have the schools that are supposed to pick up the the things that Babies Can't Wait was working on. Um, it was We had occupational therapy, speech therapy, because she have, as you said, talk about textures, and she has to always wear socks, and she doesn't like her feet to touch the floor, or things like that. But when she got older, then we started to look at more of some of the behavioral pieces of that. As we all talked earlier about social skills, there are some things that we know we would not do socially, but there are times when Gabby may do something that's not sociable, but she does not even understand that it is not something that we would do. For instance, when she was younger, it was always going to a trash can. It didn't matter where we were at. When I had to take her to the doctor's office, I had to scope out the room and make sure that I'm a step ahead of her. And I had to make sure that I was on it and to learn what some of her ticks or her things that she would do, so that I can make sure that when we're in that setting, it is not as inappropriate as it would be. And as Dr. Walton was saying earlier, it really does take a village. I'm telling you, it does. I mean, I'm not going to say I did not cry many nights, just trying to make sure that her needs were being met. But bringing in other services, like we also talk about Babies Can't Wait. Also, there were services with Medicaid, the Medicaid waiver program that offers the waivers for parents for their children who have an intellectual disability. And Gabby started to receive hers when she was 10. And that gave the respite for me, for the parent. And it also gave us an opportunity to have staff to come into the house to work on whatever the behavior plan is or whatever the ABA is. We worked as a team to get it together. So the staff at the hospital, we have the medical side. Now we got the in-home side. Now we got the community side, because we also have our county has a disability program for those for social skills. So I had to plug her into everything, anything that I could find, anything I heard. And also, I'm on a lot of groups on Facebook that have parents that are sharing some things that we just don't know or haven't seen. And it's another way to get information.
Is that an
Without,
open group, Ms. Collins? Or can you share that with our listeners, which group that is?
yes, I can share that with the list, and I can make sure it gets
Yeah,
to.
put it in our private chat, and we'll put it up at the bottom as a banner. And
Okay.
then while we're doing it, could we put the question up from Ms. Briscoe? Ms. Collins, as your daughter transitioned to becoming an adult, what was your experience in finding adult medical providers that were familiar with autism spectrum disorder? Thank you for that question, Dr. Briscoe. And I also say Dr. Nunez. I swear I did not plant Dr. Briscoe and Dr. Nunez. They were my classmates at med school. They are supporting me, and I'm so grateful that they're listening in. But that's a great question from Dr. Nunez in the past, and now Dr. Briscoe to Ms. Collins, adult providers.
Well, yes, when she left her pediatrician, of course, we were sad. But what I did, I had started interviewing and looking around and posting on Facebook, for recommendations of physicians who work with kids, adults with intellectual disabilities. So I got a person sent, messaged me and told me of this one doctor that's in Stockbridge, Georgia. So I went to her the first time, and we love her. She works well with those adults with special needs. She takes her time. She explains to me what I need to do. Even though we do have a psychiatrist that works with the other part, but all the medical part, we work with Dr. Joy Nichols. And if you have a good provider, you're in good shape. Let me say that, because you want to transition to someone who, of course, has the knowledge, the skills, and the patience, to deal with everything that comes. Because when we walk in that door, we're all coming together with all of our problems, and to have someone to do that and to make sure that Gabby gets the right reference, or referral, I'm sorry, right referral, and making sure that we're doing what we need to do. So, interview doctors. It is okay. It's okay to do that. And I had to start doing that a year before she was let go from her pediatrician. Don't wait to the last minute. Some of these things we just have to plan them out. I know they were tiring, and there were some doctors that I did have a conversation with that I just didn't like their vibes, but you just have to plan it, and you just have to work it and make sure that Gabby likes that relationship with Dr. Nichols. You know what I'm saying? So there's no, I don't want to go to the doctor. I don't want to draw blood. I mean, she lets her do everything. So I would, suggest that when they get ready to leave their pediatrician, that year before it's the end, start asking around and start interviewing these doctors.
Thank you, Ms. Collins, for adding. I want to add to that because I'm so glad transition got brought up. She's absolutely right that you have to sort of set it up before that. So there's actually policy in the works that actually all pediatricians and providers, once your child turns 14, you should actually start having the conversation. So by the time the child is 18 or 21, already start having in mind, all right, this is my next provider I'm going to go to, or whether it's going to be an adult med provider or a family practice provider, or however it works. You want to start that process early, because just like in school, your individualized education plan, there's an ability where you start talking about transition. When? At age 14. That's per education law. So the same applies when it comes to the medical field. You got to start having those conversations early and not at age 17, 18. Or else it's going to be almost a train wreck, okay? And then you're going to become very overwhelmed and stressed, and that's not going to help anybody. So I just wanted to add that. Thank you for that.
And if I can add one more thing, you're right, because when she graduated from high school, when we was having that conversation, they said, "Where's she going?" I said, "We already got that already worked out. She's, she's
See?
going she's going to a day center because I've already did the Medicaid waiver, the buddy's sitting there, and when she transitioned at that 21, I interviewed some places, some day centers, and I asked around like some of her special needs teachers and asked, and we found one. Again, Gabby loves the facility. It's a small facility. She's very open and warm and very attentive to all the adults at that center. So you can't wait to the last minute. That's all I'm stressing. Do not wait to the last minute.
Fantastic. We have another question from the audience. Kelly Lene, thank you so much. Dr. Lene, thank you for being a physician and participating. She says her daughter had a great pediatrician and good teachers, and we all missed it. She wasn't diagnosed until she was 23 years old due to her insistence on having a diagnosis that explained how she felt. She knew ADHD nor anxiety made total sense. They just thought she was just shy. So if I could have a Dr. Lawson come in and talk about how do you differentiate somebody that's just shy and adapts versus an autistic girl? Excellent question, Dr. Lene. Thank you. And Dr. Lawson, could you take that one?
Yeah, I think in terms of some of the features that's already discussed, the point is the person really just shy, or do they just want to avoid eye contact? Do they have mannerisms, or are they or are they just trying to be entertaining? And the features is the same features as in autism. The difference is that some kids learn very early. This is the way you behave if you're normal. And then can mask it by saying I'm being a comedian, or I'm doing things differently. But if you see the problems of eye contact, communications, difficulty in terms of communicating feelings, missing key points when you try to make a joke or something else, that suggests that you may want to take things in terms of a different direction.
Thank you for that. Thank you for that. You know, one of the things I'm hearing when I listen to Dr. Walton, Dr. Lawson, and Ms. Collins is that none of these things happen like a light switch overnight. You need to think about it. You need to interview providers. You need to plan for the future. That's something I do in peds rehab all the time when I start talking about transition stuff. Like Dr. Walton said, at 14, I didn't know that was some number everybody else used. That's the number I use, because it's not just finding providers, but it's making sure your funding source doesn't turn off when you turn 18 or 21. Will it continue as you're an adult, or do you have to reapply? Do you need to do a medical or legal power of attorney? Because it's assumed that parents make decisions for children, but it's not assumed that parents make decisions for intellectually disabled adults. And all of those things take time. They're really, really hard to do in a span of weeks. It's overwhelming. There's a lot of paperwork, and people don't move quickly at any of these agencies you have to deal with. So I really want to leave our audience with the nugget that give yourself time, give yourself grace, and give yourself a chance to work through the process. If you think you need to start 2 weeks, give yourself 4 weeks. If you think it's going to take you a couple of days, give yourself a couple of weeks. Because I think it's really speaking to letting the process move through how it's going to move through. There's a couple of Facebook groups that are out there. They're called We Are Proud Autism Parents, Special Needs Moms Network, Autism Parents Support and Discussion Group, and Advice and Support for Mamas of Autism Children. So there's lots and lots of groups out there on Facebook on this platform. Parental and peer resources are as important, if not more important, than the clinical providers that you're seeing. I think my colleagues would agree with me on that, because there's some things that come from being a mom or a dad that are different than being a provider that provides care. There's things that you want to know about when the rubber hits the road that another mom or dad is going to be able to explain to you in a different way. And I think that's important. Thank you. Go ahead, doctor.
I just want to add a couple of things, and I'm glad we're putting up these resources. I also want us not to forget Autism Speaks. They actually have been pushing, as well as the CDC and other organizations, definitely, as we're speaking to the Black community here, more diversity and more understanding, right? And so there are definitely outreach directors from Autism Speaks that are Black that sort of know, like, we really need to reach out to our communities that have been through the process, been through it and experienced it, in terms of, all right, these are areas where you know you're going to need your advocacy. Though this one is not autism specific, I do want people to be aware of the National Disability Rights Network. This is regarding any individual with a disability where you need advocacy. So when Ms. Collins was talking about how the medical system and the educational system disagreed on, should we have this autism diagnosis, which will happen, I will say, they don't have to agree. The education system's doing a classification, not a medical diagnosis. That's two separate things. But you may need what's called a parent mentor or a parent advocate, and each state may do it differently. But the National Disability Rights Network is where you would go, so then you could determine what happens in your state. And this can go to not just our families out here with just children with autism, but with any developmental concern. I want to make sure you guys can reach out, because basically they're like attorneys. If not, they know who to go to next. That's a go-to person, because advocacy is real. It is necessary. You are going to fight. And please don't give up. I'm telling you, parents, guardians, grandmothers, aunts, all of that, let's just be real. You are the number one advocate for your child. You are the number one advocate for your child. I will always advocate till I die, but in the end, in that room, and I'll call into an IEP meeting if I have to. I've done it before. But you are the number one advocate. So my job is to equip you to make sure you have what you need and know what to say, so that way you get those needs met for that child. That's extremely important.
Dr. Lawson, you want to add on something there?
Absolutely.
Just 1 second, Ms. Collins, we're coming to you next. Go ahead, Dr. Lawson.
Yeah, I agree 1,000%. Many communities, many African American communities, there aren't advocates already there. We may often have to become the advocates. I became involved because I was helping several mental health association groups. So what topic we have? One of the members had a child with autism, and I discovered that even though there were a lot of programs, most of them didn't talk to each other. People weren't aware. There were speech therapists who worked with autism. There were legal professionals who worked with them, but none of them worked together. And another one that I was very impressed with, so having a church member had a child with autism. The church then became her family and became very supportive. And I'm Baptist, my wife is Catholic. She has a church that has a very similar kind of program. So our community, our churches can be advocates for autism.
Thank you, Ms. Collins, please.
And I want to say this. It's okay. I didn't do everything right. So I made mistakes along the way, and I just I learned from my mistakes, and I kept going. So I don't, I want parents to understand that it is hard. I'm not going to say it isn't. And I have made plenty of mistakes, but I got up, wiped the tears from my eyes, and moved on to the next thing that I had to do to make sure that Gabby received the services that she's entitled to, as I explained to some of these schools or programs that, you're not doing me a favor. You're doing me what you're supposed to do for my child. Those are two different things. And I expect the school to do what they're supposed to do within that IEP. And as I was mentioning earlier, we were fortunate to get Gabby a one-on-one parapro until she got to high school. And they fought me every year, and I would always come back, well, you didn't put it in the IEP that we were going to transition her out. So then they couldn't do that. So then, it just to make sure that you can connect with someone. And again, it's okay to make mistakes, and that's fine. And we just have to learn from that, and then we just have to still keep going.
One thing, Dr. Walter, before you come in, I just want to say thank you to everyone listening. If you all are just joining, this is NMA Talks. We're focusing on autism in the Black community. We have wonderful panelists, Ms. Pam Collins, who is a mom, Dr. William Lawson, who is a psychiatrist in Washington, D.C., Dr. Jennifer Walton, who is a developmental pediatrician in the great state of Ohio. I won't say the Ohio State because y'all get all amped up when people say stuff like that.
But it is what it is. It is what it is. I'm just
Dr. Walton, please.
And I will say this. Please note, there is not a teacher on this panel, and I respect that. We are not bashing teachers, to be honest. There have been some fabulous, magnificent teachers. There are some IEPs that are the best I've ever seen, to the point where I say, oh, Mom, I wish this could just be imitated and duplicated in this school district. So I do want to say they are a valued part of the team. To be honest, they will pick up on things that sometimes we don't pick up on. So I do want to say this is a team effort, and that teachers, you are definitely needed, definitely wanted. And the goal is, we always want to work together. We are in systems that will not agree. And sometimes in that institutional and structural system, that's where bias and discrimination exist, which actually leads to why there are those in our African-American community that aren't diagnosed as timely as we should. And so that's what we need to start breaking those barriers on. And so I want to make sure we have that understanding that we're always still going to work as a team and really break the barriers of the institutions we come from. So that way we can really give our children and our adults with special needs the best treatment.
Fantastic closing remark from Dr. Walton. Let's have a clock built in. As we approach the top of the hour, to be respectful of everybody's time, I wanted to give Dr. Lawson a chance to say some closing remarks. And Ms. Collins, get ready. You're going to bring us home at the end.
Just want to note that, by the way, I am a teacher. And I'm always amazed that autism is treated as isolated from the rest of the community. But I run into folks pretty much all kinds of experiences, including among medical students as well as among residents. And I actually had a partner who was a medical student who had autism, but who was diagnosed late in life, was managed to get through medical school. So again, the brain is too important a tool to waste. We got to do more to make sure that more of our folks get the opportunity to do what they're capable of doing.
And my last words is love on them, love them, nurture them, hug them. Regardless of what's going on, we still have to say, we kiss every morning and every night before she go to bed, and just make sure you still just give them that love, regardless of what type of diagnosis they may have. But that feeling of being inclusive and loved is the best thing you can give.
Wonderful closing thoughts. Thank you to my panelists, Dr. Jennifer Watson, Dr. William Lawson, and Ms. Pamela Collins. My name is Dr. Maurice Scholes. I am a peds rehab doctor from the great state of Louisiana in New Orleans. I'm also a board member from your National Medical Association, and I'm proud to be here with NMA Talks. I would be remiss if I did not thank Ms. Jennifer Young and Dr. Shonda Nicole Holsey for their wonderful support of this process, and also my fellow committee members in the social media and branding committee of the board. Thank you for all that you do. Everyone that's listening, if you want to talk to us later, shoot an email or a text message to National Medical Association. You can find any of us. I'm at Doc Mosho, DOCMOSHO, on Twitter, Instagram, Facebook, whatever you got it. Find me, reach out, and we'll make sure your questions get answered. Thank you for a wonderful show, you all. Thank you very much, and good night.
Good night.
Good night.